Welcome to our second day of the Symposium. My name is Jenny Reid. I work for the government, so I suppose I'm a bureaucrat and have been for a very long time. But in being so, I have had the pleasure of working with some of these esteemed academics we have in the room with us. And I'd like to say it's a real pleasure to be introducing this session on food monitoring. So my very first exposure to food monitoring and to some of the academics here was, here's my photo, historical photo, in the Nutrition Task Force. And you'll recognise some of the faces in this group. You see Robert Beaglehold, who was here yesterday, but it was my first time I met Jim and Winsome and some of the other people in this group. And this was the first time that I was aware that there was a real appetite with government to be working in food and nutrition, to be looking at getting a multi-sectorial group together and really committed to investing in that group to developing a food and nutrition policy. And as a result, we had Food for Health, and for those that don't have it, it should be sitting on your bookshelf. It is still very current in a number of the areas and recommendations that it makes. And one of the things I wanted to pull out was the chapter that referred to surveillance. So surveillance and monitoring implied regular monitoring and evaluation, including food supply and consumption, health statistics, health status, food legislation, and food and nutrition education. I mean, that could come out of either the Ministry or Ministry for Primary Industries these days as well. So it's stated that surveillance and monitoring includes evaluation, which is essential for the assessment of the effectiveness of the policy implementation, and provides factual information for the future direction of the food and nutrition policy. So it will be interesting as we have this next session to see where we are in terms of both our data monitoring and how that might be being used to feed into food nutrition policy. So we now have the privilege of the insight and wisdom of three key speakers for whom food and nutrition monitoring has been their bread and butter or their bread and margarine. They have all added significantly to the collective trans-Tasman and global knowledge regarding food and nutrition monitoring. So firstly, Winsome, can I ask you to come to the podium? Winsome has an academic career spanning more than 45 years. She has been pivotal in the food nutrition monitoring in New Zealand with her work in all of the key surveys. She was the instigator of the food composition database, which still has a really important legs in our global and national status, and has a real passion and recognition for both child nutrition and food security. So Winsome, can I pass to you?
Thank you, Jenny. Am I working? Don't need that one. Thank you for that introduction, Jenny, and Jim and I were sitting and thinking how much younger we looked in that photograph. But a very warm welcome to you this morning for battling the traffic in a warm day and coming to this presentation. And I'm assured although I'm retired, I'm allowed to say colleagues, and I do regard many of you as that, but also to my whānau, who are in a special row there. And I'm somewhat nervous because there are people there who lived with me and worked with me through all the surveys that I've worked on, and if I put one foot out of line, they will know. Just keep it till afterwards. I will do my best to represent things accurately and to convey to you the excitement and the hard work that's been done. I was quite moved yesterday when Mark Brunton in the mihi at the beginning mentioned how important it was to honour those who had gone before. And I thought, in some senses, that's what I'm attempting to do today. I'm not a historian. I have half of a history degree, but I never finished it. And I want to tell you some of the stories of the hard work that's gone on in New Zealand in which those of us who worked in this area have built on. And what I want to convey to you and what the other speakers do is that we need to go forward. So don't regard this as the ultimate and the way that we have done things in the past as the only way to do things. At the end, I want us to be able to take our hats off and say, how can we be creative and how can we go forward? And so if that's your interest, then please come to the workshop this afternoon. Even if you haven't registered, we'll put you in a group and hear what you have to say. A very brief definition, it says WP, that just means that I created this definition, I didn't take it from a textbook. But I'm talking about dietary surveys, so for those of you who haven't been directly involved, what are they? And they're collections of data describing the intake of foods, beverages and supplements, because we do consume those for populations or groups of people, so that we can make an assessment of the adequacy of the intakes of energy, nutrients and food components. Now I would make the comment that when you do dietary surveys you can't really assess energy balance, because we're not in most of them assessing energy output. And so looking at energy intake will not tell us whether we should or shouldn't on that energy intake get larger or smaller. Only the notches in our belt will tell us that. Of course, a full nutritional assessment, as most of you with a nutrition background know, requires that you have to do more than look at food and dietary intake. You have to take some blood samples and look at what's going on in our biochemistry. You need to measure, see where our body fat is, how it's distributed, and to also do clinical assessments, at least check blood pressure and other things as well. But I'm going to focus today on dietary surveys in New Zealand. Well, I can go back to 1926, which I think is pretty good. Years ago, I had a summer student collect information on dietary surveys in New Zealand, and I didn't throw it out. I was very grateful for that box. So going back to 1926, in Dunedin, they did this work, although the data were collected a little more broadly. There was a study of 710 families, quite a lot of work, and they looked at the menus that these families had and the foods that they ate. Now, these were week-long surveys in households, and it was in the days before people ate at cafes and bought takeaways, and so what went on in the household told you almost all that you wanted to know. That household survey technique, Flora Davidson taught me years later, it wouldn't work today. So it reminds us that techniques used have to be relevant to the era in which they're carried out. So the two people who did that were Neige Todd-Hunter and Lillian Storms, and they published the data. Now, Neige Todd-Hunter then moved to the US, but is known as the Neige Todd-Hunter Scholarship, which is given annually. And Lillian Storms was one of our first food chemists. She was especially well known for measuring calcium in foods. But what did they conclude when they wrote up the data? They said meat intakes were high. Boyd Swinburne's not here, but you're not the first to say that, Boyd. They said that fruit, brown bread and green vegetables were scarce, and what they meant was scarce in the dietaries of the people they studied. And then I've just pointed out what these people's background was. The professional concern about nutrition in New Zealand was really triggered by the Depression years, and I think that's interesting that it was a response to what was happening when there was a lot of poverty that the professionals said we have to have a look and see what's happening and then decide what we can do about it. And we owe a huge debt to Muriel Bell, and as most of you will be aware, there's been quite a lot of publicity lately as her biography has just been published, but she qualified in medicine here and was also she had postgraduate qualifications in public health and biochemistry and physiology, a very broad base, and an interest that spanned everything from agriculture and food production up to human health. So she was able to look at the whole picture. She formed a formidable team really with Dr. Elizabeth Gregory, who was the professor and dean of the School of Home Science. She became dean in 1941. And both of these women I was privileged to meet. I was at the Muriel Bell's graduation when she received her honorary doctorate, sitting well in the back row. And Elizabeth Gregory used to come into the Home Science School and have morning tea with us when I was a junior lecturer. So it's not that long ago. But the important role these women also had, besides the research that they did, was that they were part of the Nutrition Research Committee. Now, that was a committee of the New Zealand Medical Research Council. They were inaugural members, probably only the two women on it, and Muriel Bell actually led the Nutrition Research Committee for several decades, and her influence was profound. The next piece of important research was carried out in 1934, and it was a study of 170 families. And Elizabeth Gregory, who worked with Jackson, Chambers and McLaughlin, took care to select the families they studied across the socio-economic spectrum. They wanted to look at what people ate, whether they were rich or poor, essentially. And again, they had households collect records of everything that went in and out in a week. That's actually quite a respondent burden if you think about it, but families were willing to do that. And they calculated the amounts eaten per person. They couldn't differentiate between the members of the household, but there are weightings that you can apply. They compared the intakes to recommendations. Most of those came from the US, from Sherman at that time. And they published the results in the New Zealand Medical Journal in 1943. You can find it. You probably have to go to the Hocken Library. And their conclusions were that calcium intakes were low, also thiamine, riboflavin and vitamin C. And their main reason when they looked at the food was that they felt that intakes of milk and cheese were low. So Muriel Bell didn't ever stop short of looking at the results. She wanted to do something about it. And of course, through the Nutrition Research Council, she was able to influence policies at government level. And so, as a result of her lobbying and hard work, there were subsidies put on dairy products that were available for consumption in New Zealand. So when I was small, milk was still 4 cents a pint. It was subsidised. When you pay $4.50 for the big container now, think of that. She was responsible for the establishment of town milk councils, which meant that when milk was delivered, it was put in covered boxes, it was fresh and looked after. And the instigation of the free school milk scheme, and I know there's people in this room who had free school milk. My husband says he loved it, and I hated it. Partly because I'd been fed too much porridge before I got there, and I just was not hungry. A further examination of that very same data set came up with some important findings, and McLaughlin looked at the poorest group within that cohort, those who were the basic wage earners. They were not beneficiaries, but they had low income. And when she looked at that and published it, she particularly noticed and commented on the cost of healthy food, the cost of fruit, green vegetables and milk, and said that was a barrier to their purchase and consumption. Has anything changed, I ask? She also noted that the fraction of cereal consumed that was unrefined was considered very low. If you were here at the Fibre Symposium yesterday, again, the concerns have gone back a long way. The result of this study, they said we need to look at a Māori group, and so they studied 50 Māori families that comprised 315 persons, so it wasn't insubstantial. And when they looked at that subgroup, they found that their diets were low in calories, iron, calcium at a gross level of lowness, and vitamins. But they also noticed that Māori had a tendency to fatness. That's their words, not mine. I should have put it in inverted commas. We didn't worry about being PC back then. And so there was the enigma that it appeared to be a low energy intake, but perhaps all of the energy hadn't been reported. But there was a concern above that, concerns that they had with the non-Māori population about calcium intake and some vitamins. Now, as time moved on, the dietary studies throughout the 1950s, I couldn't find many published in that time, or any, in the 60s and 70s, what was happening. Well, this was the era of the Department of Health, the forerunner to the Ministry of Health, of course, and it had a nutrition section. And that nutrition section was actually there to be advisory to the Minister of Health on matters of nutrition and dietetics, and it wasn't intended as a research entity. However, within that unit we are indebted to Flora Davidson, who was a dietitian, but she gathered others around her, and Flora loved to do research, and so she found teammates at Wellington Hospital's medical unit, later the epidemiology unit, and the director was Dr. Ian Pryor. And those of you who were here and heard Robert Beaglehole speak yesterday, Robert and I shared an office for quite a number of years in the epidemiology unit working for Ian Pryor. But Ian's first foray into dietary work was to work with Flora to collect dietary data. And so there were a number of studies carried out in Europeans, and I'm going to talk about Carterton study in a moment, amongst Māori and Polynesian groups, the Pukapukans and Tokelauans. And Robert also referred to that yesterday. He had, as you would have heard him say, been back visiting Tokelau and was distressed at what he saw in matters of health and diet. But it was this team of people who started as part of the whole medical surveillance, because they were interested in all of the non-communicable diseases, but started to look at the diet. The European study that I mentioned was the Carterton Survey, and it was carried out in 1964 amongst European New Zealanders, just a small town. I think they studied it because it was handy to Wellington and the team could get up and down quite quickly. But it was a very comprehensive study. So there were medical data collected on these people. They were weighed, measured, there were blood samples taken. And on 423, there was a qualitative diet recall carried out, not quantitative, but it did give a good description of what those Carterton people were eating. And then on only 16 households, a very detailed household survey was carried out. And those results are published, again, in a journal. It was the Journal of the New Zealand Dietetic Association, which I think at that time Flora was editor, so she managed to... the papers were peer-reviewed, and she published the results there. What did she find? Well, amongst the quite interesting findings was that there'd been a 5% rise in the energy sourced from milk when she looked back to the studies of the 1920s and 30s. And why did that happen? Undoubtedly because of the policies that Muriel Bell had instigated. So a good way to check that policies instigated had been effective. She noted that total fat intake provided about 39% of energy, and of course there was a high proportion of saturated fat, but at that time the food table didn't allow that to be separated out. Now, I was really interested in this because it's something that I think we often forget. They noted in writing up those data that there were marked differences in the food choices and habits of males versus females. It's always fascinated me because we live in the same households. Why are they so different? I'm not going to give you the answer. You can talk to me later. I've got some ideas, but not an official study. She noted that men added 3 times as much sugar to foods and beverages as women, and that men added salt more liberally to food than women. 1977, an important year. Now, just prior to that, there had been a collection of small surveys looking at vulnerable groups of the population. Now, mainly these surveys had been done by people studying nutrition at the University of Otago in the School of Home Science, and their postgraduate students needed studies. So there were studies of preschool children, of the elderly, of men living alone, and the results, I can find them. They are most of them published, but at least they're in all the theses of the department. But the Heart Foundation were putting out reports describing coronary heart disease prevalence in New Zealand, and they said, well, we know that these rates are far too high, this is important, and we have ideas about the dietary factors that are less than ideal, but it's time we studied them. And so the 2 reports in 1971 and 1976 were key to the impetus to carry out the first dietary survey, which was funded by the National Heart Foundation. And we owe a great debt to Professor John Birkbeck, who I understand visited Dunedin a week or 2 back, but I didn't hear about it. And he was coming back to where he had worked very hard to arrange a research team and carry out a national survey. There are just under 2,000 adults between 20 and 64 years. I'm not quite sure about the cut-off, but I think there was some anxiety that older people might not remember what they ate. We found that actually that's not true. The method, an individual 24-hour quantitative dietary recall, and it was collected, of course, on paper, and there were interviewers who went into homes and collected those data. There were anthropometric measures, extensive anthropometric measures, because that was John's special interest, and there was information on smoking habits gathered. So the total fat intake from the first analysis came out at about 40% of energy, which is very close to what Flora had assessed earlier, and 20 to 25% of men and 30 to 40% of women could, on the criterion that he used, be considered obese. So it's not new. We reanalysed the data with a slightly more robust food table a little later, and the percent energy from fat, I think, came down to about 39%, but it was close. And John's big conclusion was that New Zealanders eat too much relative to their energy expenditure. Has it changed, we ask? So as a response to this, there were national nutrition goals set by the Nutrition Advisory Committee to the Ministry of Health. Now, these were precursors to the later dietary guidelines to which Jenny has already alluded. I just want to interpolate here to say that one of the important things if you want to translate data about food into data about nutrients is you need a food composition database. And Harding and Karras, Harding was my maiden name, were having lunch together in Wharirata at Massey University, that's the staff club, and Harding moaned loudly about not having a good database, and Patricia Harris said, but we've got an excellent database for our animal feeds, Winsome, what are we going to do about it? And so with a bit of funding and pushing and pulling, there was the initiation of the food composition database, and it was then DSIR in Palmerston North. So lunchtimes can be very important in making decisions. And the other thing that really had upset me was the hours and hours spent analysing data by hand. It had taken me 6 months to analyse the data that I brought back from Tokelau with a calculator in my hand, pencils, checking and rechecking, and I said, I'm not going to do that again. So we had food composition database, and then we started thinking properly about the use of computers. Barbara Burlingham, who many of you know, later worked for FAO, became a manager of that database and moved it forward. And of course it was actually based, we got a copy of McKenson-Widdowson from the UK, that's the UK Food Composition Database, on paper tape. I wonder what we did with it. It must be in somebody's archives. Anyway, the data, of course, were continually replaced with New Zealand data, and we've been pretty good at analysing New Zealand food. So there were already some analyses that have been carried out, and so there's very little of the old McKenson-Widdowson data in that database. It's mostly been replaced. Not all with New Zealand analyses, but the best that we can do. And of course, that database has been more recently situated within plant and food research at Palmerston North, and a large amount of the funding for that has actually come, we're grateful, to the Ministry of Health. And then we are profoundly grateful to the Hillary Commission for Recreation and Sport. Now, if you want the details of that, Professor David Russell is here, and he can tell you a lot more about the Hillary Commission than I can. But people asked me questions a few days ago, and I hoped that David would be here to answer them, so don't run at the end of this, David. But David, who had been the Dean of Physical Education, was able to work with money from the Hillary Commission to collaborate, and there was a large survey carried out in 1989, the Life in New Zealand survey. And they collected unique data, which I'm pleased to say is still in the Hocken Library, on physical activity, leisure activities, and reasons for participating in various activities. There's never been such a comprehensive collection of data, and I will just quietly tell you the Hocken Library suggested that it took up too much space and we just quietly do away with it. It's still there. May it stay there until perhaps we can scan it, but as long as it's not lost, it's very important data. Nutrition was a part of that, and Tony Worsley, who was in the department at the time and then moved back to Australia, was important in this. He worked on developing 2 food frequency questionnaires. They had 2 because I think they wanted to know which one was best. At the end of the day, Carolyn Horvath and I combined the data from them both. They were both good. And a quantitative 24-hour diet recall was carried out on 1,602 adults, and again, the data had to be collected on paper. There were anthropometric measures, blood pressure measurements, and blood lipid analyses as part of the dietary component of that survey. I came on board at the time when the data were being analysed. Jim, it's your fault. You and David, they had a lunchtime meeting to which I was invited. I had no idea why I was invited to that meeting. And the next day I got this letter signing up as a principal investigator of this survey. And Caroline and I were sat in an office and said, get going with some of the analyses. So, what did we find? That total fat intake contributed 38% of energy, so not a huge change, fairly stable from the preceding decades. But the important thing about the data from the survey is they were used to shape the development of the dietary guidelines that the Nutrition Task Force, Jenny showed you the picture, put together. Now, that group was, the most important thing about it, in my view, was that it was multidisciplinary. And so, when you're putting out dietary guidelines, if we, for example, said, well, you should have fish twice a day or every day of the week, would someone put up their hand and say, we can't afford that, we haven't got enough affordable fish? Well, if you were on that task force, you would have got caught, because we had people from the industry, people who understood all about food production, so you could not make recommendations which were unachievable. That was a very important part. We had a health economist there, we had dietitians, nutritionists, medical specialists, and so we had to listen to each other as the dietary guidelines were put together. And they came out as food-based guidelines, and other countries of the world at that time were putting out guidelines couched in terms of nutrients. And of course, people understand food and not nutrients. Then the government must have been listening, and so the first government-funded nutrition survey was in 1997. And the Ministry of Health very bravely formed a technical advisory committee to plan and oversee the survey. And some of us had the interesting position of being on the technical advisory committee and then ending up as part of the provider team. So that made it quite difficult when we later attended advisory committee meetings. We had a bit of a conflict of interest, which we declared. So what happened was that they contracted out the data collection, the analysis of the data and the report writing to the Life in New Zealand Activity and Health Research Centre, which of course had arisen from the Life in New Zealand survey, and Professor David Russell, who's here today, was the director of that unit. And Otago University did end up really, through the staffing, contributing to the cost of that survey. The data collected were wide-ranging. There was a qualitative food frequency questionnaire, and that had been specially developed and validated for the study. Carolyn Horvath did intensive work on that prior to starting. And a quantitative 24-hour diet recall. It was a computer-based dietary data collection. So I'll just tell you why that happened. The Australians very kindly invited us over to see. They had just recently completed a study, and they were coding the data at that time. It had been collected on paper, and we were allowed to observe what was happening, and we're very grateful to that. But they'd actually had to have two sets of coders. The first set that they had couldn't cope with it for a number of complicated reasons, and it was obviously a time-consuming, expensive, difficult task. And I knew that there were ways to collect data online and to take away that coding everything manually step. So I came away and I said to David Russell and Nola Wilson, let's develop something to collect the data electronically. And in an incredibly short time, we did achieve that. If ever you're critical of the program that we used, remember the number of weeks we had to do it in, and I'll tell you, it worked. This study had nearly 5,000 free-living adults from 15 plus years, so if you had a good memory, you could be in this study. And we had not just one 24-hour recall, but on a subsample, we had repeat recalls, and that enabled us to calculate the usual intake of the population, not of the individuals, and calculate the probability of inadequate intake of nutrients. The anthropometric data were collected, as always, and very thoroughly. Nola's husband, Barry, was very important. He was a member of the phys ed school staff and making sure that we were trained to the nth degree. Blood pressure measures were taken and non-fasting blood and spot urine samples. So just if ever you want the results of these, it's all available and published, and I have a reference list that anyone could see or I could pass on to you if you wanted. You'll be here all morning if I started on results. The unique data aspects were that we presented the data by quintiles of deprivation. So again, we were interested in the socioeconomic aspects of the spread of intake, and we had the newly developed index of deprivation, which we owe to Crampton and Salmond, a huge debt as they developed this. So instead of just looking at income as and economic things, we had a whole index of deprivation which incorporates many aspects of poverty. The level of household food security, Jenny Reid had completed her master's degree and had come up with 8 indices of food insecurity, which we picked up and used. We developed them slightly for this survey. The other important thing was that we were able to present data for New Zealand Māori compared to New Zealand European and other. We had a small Pacific sample, but not a large enough one to allow statistical comparisons, but it was descriptive of the intake of the Pacific population. And it did appear that the Pacific group were perhaps the most disadvantaged and had poorer diets, but we couldn't say P equals 0.00 anything. The Ministry of Health then went forward and funded a survey of children. Now, this was carried out in 2002, and there's a lot of current concern that that is a while ago. It is. They did some extensive pre-testing, and after that, there was a consortium, the University of Auckland, Massey University, Palmerston North, and University of Otago collaborated. And David Scharf is here, who's from the University of Auckland. So we've got no one from Palmerston North here. The old team is not quite complete today. This was a school-based survey. Schools were sampled in New Zealand, so that was why it was children 5 to 15 years. Over 15 and you were included in the adult survey anyway. And the data included a qualitative food frequency questionnaire, which was tested for repeatability, quantitative 24-hour diet recall, plus recalls on a subsample. There was a lot of interest in how the children would go in remembering their diets. They're brilliant, and they have no preconceived ideas about what is good and bad, and so they're very happy to tell you anything. Their mothers would say, well, they took to school, and they would describe the lunch, but I gave that to Jodie, or I didn't eat that, Mum, or I don't usually eat the crust, they told you all. Thank you, children. We collected information on their physical activity. There was data collected on their dental health and the onset of menstruation. We couldn't find any way to check the stages of puberty with the boys that worked, was honest and was acceptable. We tried. There were blood samples taken and urine samples. That was all done in the school setting. Everyone said, children will not give you urine samples. They didn't have a problem. What did the findings include? Well, when you looked at the ethnic groups, because we had about 1,000 of each, so able to make good statistical comparisons, the New Zealand European and other children compared to Maori and Pacific came out best. They had the lowest levels of inadequate intake. That's a double negative. So they were the least likely to be obese. The highest levels of obesity were among the Pacific children. There's been a number of subsequent papers published on that issue. So when you look at all New Zealand children, remember that there's an ethnic mix and a difference. The diet quality of the children was pretty good when they were 5, not so good by the time they were 14 years, 11 months. I read the entire report and came up with this, what appeared to me a real slide in diet quality. And I thought, dare I say this? So Jim read it because I think he was writing the foreword, and independently we came to the same conclusion. 2008-09, an adult nutrition survey was carried out, again funded by the Ministry of Health. The University of Otago were the providers, particularly of the dietary data. The sample selection and enrolment was carried out by CBG Health and Research Limited, based in Auckland. And we collected, again, dietary and anthropometric data in the home. We've always done this because people can show you the bowls they use, the size of containers, and you get very accurate data. If you do recalls over a phone or have people assessing the size of portions, you don't get such precise data. And the participants happily attended clinics that were associated with Canterbury Health Laboratories to provide blood and spot urine samples, and that worked extremely well. The data included a dietary habits questionnaire, which had been put together in the Ministry of Health. There was, of course, the quantitative 24-hour diet recall on almost 5,000 adults, repeat recalls again on a subsample, anthropometric measures, blood and urine samples. Unique data, we had the ability to look at HbA1c, and so could assess the prevalence of pre-diabetes and diabetes, the first time this had been done in relation to a nutrition survey. The food security, we had the 8 parameters. We were able and had the means to present that in 3 categories. I'd worked with those as part of my PhD research, so we could say whether people were food secure, moderately food insecure, or had low food security, or the households of the people. And a delighting result, I think. Total fat intakes had fallen to 33.7% of energy for males and 33.8% for females. And that drop had been largely by drops in saturated fat. And later on, when Murray Skeef looked at the blood cholesterol levels and what had happened with fat, we came to the clear conclusion that the policies, really the education about what kinds of fat we should eat, reducing saturated fat intake in particular, had been effective. Obviously there's statins, but we were able to look at those. We knew whether people had statins or not, so we were able to look at that and come to that conclusion in a confident way. So, the effective monitoring of the nutritional status of the New Zealand population. We've been doing it for a while, and I think we've done it fairly thoroughly and well, but there's been a gap and nothing has happened. Personally, of course, I feel that such monitoring is essential, and particularly to chart the progress and effects of policies and education efforts. We want things to happen. There are many policies, programs that are being carried out. Are they working? And unless we monitor it, we won't know. You need to do it regularly, or you will be using out-of-date data. Now, when Tracy Hambridge speaks to you about the use of data, I know she will talk about the incredible use the Dietary Survey data of both of our countries has in it's used so that we can check the health of the food supply. In other words, we look at, if you want to put a new additive in a food, you need to model and say, well, if we put it in bread, how much bread do people eat? How much bread do people of different age and sex groups eat? How much do children eat? And so if we put folic acid or iodine or something in our food, how much will people get? Will it be effective? And so that use of the data is incredibly important. And also a new additive, if it goes in a particular food, how much will people get? You don't want to be using out-of-date data when you make those calculations, not in my view, and I think at the moment we are using out-of-date data from the New Zealand perspective. I think the data should be collected with integrity, and I thought about this and I thought, yes, we've developed the techniques. Is the most important the technique, or is it the way it's handled? Now, techniques are important, and we could have debates, many of them very fierce, about what methods we should use to collect the data, and we should move forward always in that work. However, in my view, the most important thing is that it's a multidisciplinary team who are familiar with food production, food processing and food composition and nutrition, who work together to collect the data. Now, Muriel Bell embodied all of that in one head. That's a bit difficult in today's world, and so being able to work effectively in a multidisciplinary team and communicating well is essential, because at the end of the day, when you want to interpret what the data says, you will have to have people from many different backgrounds to put their heads to that task. There needs to be excellent communication between all parties in the planning, execution and data presentation. We were very fortunate at Otago that we usually worked in a little house with doors that opened together, and David instituted the fact that we all had to come to morning tea, which is something that I later insisted on. That's where all of the problems in dealing with the data came out and all the problems got solved. It was the sharing, just the non-stressful moments that the quality of the data was affected. There would be people checking data that arrived online, curious about something. They would raise it at morning tea. We would say, there's an issue, let's deal with it. It worked. The $1 million question, and I'm going to leave you with that, is survey funding. I think I meant to put MD in capital letters. I'm sorry, it is the $1 million question. Now, you'll have noticed that I've talked about who funded the surveys as I've gone along, and there has been a precedent in New Zealand for non-government funding. In Australia, there is food industry money that goes into the surveys, and other countries have other means of funding it. We have to think creatively about funding sources, and I think we're going to start discussing this in our seminar this afternoon. But in my view, if we feel that these data are essential to the health of our food supply and to the health of New Zealanders, then we cannot say we haven't got enough money to do it. We need to think creatively about that. And so if ministers of the Crown say, yes, it's important and don't give us any money, we will have to lobby them. And if they say, well, we won't accept money from any other source, then I've got a few question marks. We do need to put our heads to this task, and so you're all invited, if you haven't already signed up, to our workshop this afternoon at 2 o'clock in the Kakapo room. I'll see you there. Thank you.
Thank you. Thanks, Winsome. That was a fascinating reflection on dietary intake and assessment in New Zealand. I've got time for a couple of quick questions. Okay, I was going to ask Winsome very briefly then. So the surveys have gone from 5 years and upwards. What are your thoughts on collecting, or how best to collect data on the under fives?
All I can say is it's very complicated, and I actually don't know the best way. A number of us have put our thoughts to that. Anne-Louise Heath has probably collected the most data on preschool children of anybody in this room, and I would talk to her for help with that. One of the big issues with preschool children is they have multiple caregivers. And the days when mum looked after and knew what her child ate for 24 hours a day, 7 days a week are gone. And so it's difficult. The Australians have some experience in this, and we could also learn from that. So we've got two sources of information. I do think it's important, and it's an area of great interest. There's no perfect method, but I'm sure that there's enough expertise for us to do something.
Jim.
Winsome, that was a great talk, thank you. Robert Beaglehole yesterday talked a lot about, the great triumph, the reducing coronary heart disease mortality rates in New Zealand. And the epidemiologists have long attributed this to the reduction in saturated fat and increase in polyunsaturated fat. And you mentioned, of course, the substantial reduction in total fat that occurred when we first got round to it. I mean, what I'm slightly missed, just in terms of the time sequence, was can we say from our survey data roughly when that change occurred, the reduction occurred, or was there too big a gap between the last, the 40% number and the, whatever it was, 30-something% number? And then the other half of the question is in relation to polyunsaturated fat. Do we actually know about that? Because I think the reduction in coronary heart disease started to become very striking in the sort of mid-70s, as I remember correctly, or the sort of 70s is when it started to come down.
I don't... The data are a little bit too spaced out to answer that question well. We didn't really, at a population level, notice a drop in fat, which was largely saturated fat, until about the late 1980s, 1989 survey, it started to go down. So in the 70s, it looked as though from John's survey that it was, from the Heart Foundation survey, that it was still high. The polyunsaturated fats haven't changed hugely in the proportion that people are actually eating. I would say that when we developed the instrument for collecting the dietary data in 1989, the Ministry of Health wanted us to collect detailed data on fat. And so we developed an instrument which asked extensive questions about the fats that we used. And in a sense, a lot of that has never been fully explored. But when people were asked if they, what they cooked their food in, they couldn't just say oil. They had to specify what kind, which in most cases they could. So very detailed data were collected. But as I recall, the total polyunsaturated fat intake has changed very little.
Did the Birkbeck data have a breakdown of fat? I can't remember.
Yes, it has saturated to polyunsaturated fat ratio is the way that
and
that's
it was
published.
still high for saturated fat in the
Yes,
60s,
yes, it
whenever
was.
it was. Yeah.
Yes, it was.